Hello, everyone, and welcome to the concept overview for alterations of cardiovascular function 1. Now, I know in your anatomy and physiology courses, you cover a fair amount about the heart and the blood vessels. So what we're going to do is we're going to do a very focused review on the topics that you need to know to understand the diseases that we are going to cover. So this is very clinical and very focused. So the first diseases that we're going to talk about involve blood vessels, specifically arteries and arterioles. So we're going to be looking at diseases like atherosclerosis, where plaque builds up in arteries, and then the consequences of that throughout the body. So just a brief review of our artery structure, because we're going to be referring to all these different parts of the artery. So this is a section of a blood vessel, and it really, technically it's an artery, but all these different layers are found in arteries and veins, but let's just focus on it as an artery. So, whoops, it just jumped ahead on me. Okay, there we are. So this is an exploded view, so that you're seeing all the different layers and the tissues that are comprised the layers of an artery. So the very inner layer is this yellow layer here. It's called the endothelium, or the vascular endothelium. And that particular layer is 1 cell thick. This layer consists of what we call simple squamous epithelial cells, but more specifically endothelial cells that have a wide range of physiological actions. They secrete substances, they contract, as you've seen already, to increase capillary permeability during inflammation. They're very active cells and very, very important for cardiac physiology and pathophysiology. Now, that inner layer lines the entire cardiovascular system, including the inside of the heart. It coats over the valves, the inside of the arteries, the arterioles. The capillaries are actually just the leftover endothelium once all the other layers are peeled off. And then the venules and the veins, we start putting the extra outer layers on as we go back towards the heart. So we see this endothelial layer lining the entire cardiovascular system. Now, as we go a little further out, these dark green layers here, these are just kind of connective tissue layers that lie between some of the other layers. This layer here that has kind of the paler green and then the pink in it is called the tunica media, or the middle layer. And the term tunica just means a layer. In the tunica media, there is one of two tissues, or in some cases, there may be a little bit of both. So most arteries have smooth muscle, and these are the little pink cells. So if you look really closely, these are smooth muscle cells that are organized in a circumferential manner around the outside of the artery, and even arterioles. Of course, this particular layer here, when we have a muscular artery, this is where we get the vasoconstriction and vasodilation of our arteries and arterioles. Some of the arterioles are so small, we'll see a smooth muscle cell just wrap completely around it to be able to do vasoconstriction. There are some arteries in the body, namely the aorta, that is more elastic. So it has a lot of elastic connective tissue in it. The aorta doesn't contract. It just, under high pressures, it stretches out. And so it has primarily elastic connective tissue. And then the last layer is what we call the tunica externa. It's just an inert connective tissue layer that protects the outside of the arteries. And that's pretty much it. So the two active layers are going to be the endothelial layer, and then, which is the tunica interna or intima, and then the tunica media with the smooth muscle. All right. Well, then that just briefly brings us to the types of arteries. And as I mentioned before, we do have elastic arteries that have more of that elastic connective tissue in the wall, the aorta. And that's pretty important because when the ventricle contracts, the blood coming out of the ventricle is under pretty high pressure. And what the aorta does is it will not relax, but the elastin will stretch out. It will absorb that high pressure. And then when it recoils, it will smooth out the flow of the blood and the pressure of the blood. So the aorta becomes really important for kind of decreasing arterial pressures and smoothing out those pressures to create what we call a laminar or a smooth blood flow. Now, that's pretty much the only artery in the body that has a lot of elastin in it. Most arteries, as I said before, are going to be muscular arteries. So all of the named arteries on this picture here, which I know you've seen before, these are all muscular arteries that can vasoconstrict and vasodilate. And that, of course, is going to alter blood pressure as we start to move into talking about that physiology. Now, as I was saying, the arteries will feed into arterioles that are just before the capillary bed. So we sometimes call these precapillary arterioles. So here are the capillaries where we're going to see oxygen, gas exchange going on in the tissues, but we're also going to see fluid going out and in and all sorts of stuff, exchange going on at the capillary level. But just before the capillaries are these very small arteries, and they have these smooth muscle cells, the things that kind of look like worms. Those are the smooth muscle cells. And like I said before, those arterioles are so small that the smooth muscle cell can wrap all the way around it. Now, arterioles are really about regulating blood flow to the capillaries. So if an arteriole vasoconstricts, there's going to be very little blood flow to the tissue, usually just enough to keep it alive. Okay, so we're going to be able to see vasoconstriction and vasodilation of the arteries that affects blood pressure, and then vasoconstriction and vasodilation of arterioles, which is primarily affecting blood flow to the capillaries and the tissues. All right, well, those are the structures, main structures that help us regulate blood pressure. So the question then is, how does the body physiologically regulate blood pressure? The blood pressure is regulated by the part of the nervous system we call the autonomic nervous system. And recall that the autonomic nervous system consists of the sympathetic nervous system and the parasympathetic nervous system. But when we really talk about the arteries and the way that they regulate blood flow, the only part of the ANS that innervates the blood vessels are the sympathetic neurons, so the sympathetic nervous system. The parasympathetic nervous system innervates the heart, but not the blood vessels, okay? So all we need to do is talk about sympathetic nervous system stimulation of the blood vessels. So this here is, I'm not going to go into a lot of detail here because this is stuff you've covered in your physiology courses, or you can review in your patho book, or if you prefer a video, just Google online blood pressure regulation or blood pressure physiology. Okay, but this picture here is showing us, here's a person, and here, all these green lines here, these are sympathetic nerves, and they're going out to all the different parts of the body that are innervated sympathetically. Now, we do have sympathetic innervation of the pupil and the bronchi, but where we see the neurons going to the organs, we see sympathetic innervation to the heart, to the bronchi here, but where we see it going to all the digestive organs, for the most part, these neurons are actually going to the arteries that are feeding the digestive organs. What this picture doesn't show is all of the sympathetic neurons that are going out to the blood vessels in the body, but you have to kind of just imagine them, okay? All right, so what we're talking about when we talk about sympathetic nervous system stimulation to the arteries is really the effects of the neurotransmitters and the hormones that drive our sympathetic response. And if you recall, there's one neurotransmitter, norepinephrine, and that gets released at the neuromuscular junction of sympathetic neurons and muscle tissue that can be excited by it. Now, we'll talk about the receptors in a minute because it'll become really important, not so much for pathophysiology, but for pharmacology. But for now, I just want you to recall the baroreceptor reflex. There are pressure sensors in the aorta and the carotid arteries that are sensing your blood pressure right now. And if your blood pressure drops, let's say you become a little dehydrated. Okay, so your blood volume goes down, your blood pressure drops. There's a message that goes up to the brain saying, hey, blood pressure has dropped. We need to do something about it. And what the brain does is it turns on the sympathetic nervous system, or turns up the volume on the sympathetic nervous system. So then we have neurons that are going down and out to the arteries that are eventually going to release norepinephrine at the neuromuscular junction between the sympathetic neuron and the smooth muscle in the wall of the arteries. And that norepinephrine will do different things based on what receptor is in the artery wall. Okay. Now, also remember that in addition to a nervous system response, the sympathetic nervous system also stimulates the adrenal glands, specifically the adrenal medulla. And so we have neurons that are going to also be stimulated now when our blood pressure drops. And the neurons are going to kind of have an impulse that goes out to the adrenal gland. And then those neurons are going to stimulate the cells in the adrenal medulla to release norepinephrine and epinephrine, but as a hormone in the bloodstream. Okay. So we're going to see a nervous system effect to affect the blood vessels, and that's going to be either vasoconstriction or vasodilation, depending on the receptors. Plus, we're going to see the whole body just bathed in epinephrine and norepinephrine, and that will have a similar effect as the neurotransmitter. Okay. Another thing to just recall, we call norepinephrine and epinephrine together. Those are catecholamines. That's the family of chemical we're talking about, catecholamines. All right. So once you release epinephrine or norepinephrine at the neuromuscular junction, so at the end organ that's going to do something for the sympathetic response, now we have to start talking about the receptors. So this is just a different picture. It's more of a focus, not so much on the nerves, sympathetic nerves, but on the neurons and then the neurotransmitters. So here, this is our central nervous system and our spinal cord. Let's jump all the way to the big rectangle. And this big rectangle here, it's denoting our effector organs, so the organs that we're going to be talking about today. So we are going to talk about cardiac muscle tissue, but in our second concept overview video. And cardiac muscle tissue receives sympathetic innervation, and we get the release of norepinephrine. And here we'll see that it says here, smooth muscle. And so these cardiac and smooth muscle are both going to respond to the effects of that norepinephrine. Smooth muscle is primarily in the arteries. This is what we're talking about. And then here's just the epinephrine and norepinephrine that is being released by the adrenal medulla, gets into the bloodstream and has a very similar effect. Okay. So again, we are only focusing on the cardiovascular system and the effects of the sympathetic nervous system on the cardiovascular system, because that's what we're talking about this week. All right, well, in order to understand how the sympathetic nervous system affects the heart and the arteries and the arterioles, we need to look at the different types of receptors for epinephrine and norepinephrine. Now, there's a third name for epinephrine and norepinephrine. So we have the individual names, epi and norepi. We can also call them catecholamines, but the public or lay people sometimes call these hormones and neurotransmitters adrenaline. So the way that these receptors have been named is they've been named after adrenaline. So we're going to look at what are called adrenergic receptors. And these are receptors for epinephrine and norepinephrine, both. Okay. Now, remember from physiology, there's two broad categories of receptors. We have alpha receptors and beta receptors. So let's start with the alpha 1 receptors. So when you start really trying to learn and remember these receptors and their function, you're going to have to memorize something, one thing at least. The rest of it you can usually work out. So what I tend to recommend is that you remember where these receptors are located. So alpha 1 adrenergic receptors are found on the smooth muscle cells of our major arteries. So we're going to see the systemic arteries. Really, any large artery in the body is going to have an alpha 1 receptor. Okay. So now, what we know is when norepinephrine or epinephrine activate these receptors, it stimulates vasoconstriction. So alpha-1 receptors always stimulate muscle contraction and vasoconstriction of the arteries. Okay. What that does is it increases a parameter that we will start talking about clinically called systemic vascular resistance. It's abbreviated as SVR. I wouldn't worry too much about that term right now. I want you to just focus on the vasoconstriction piece, okay? Because what we're going to see is that if you start vasoconstricting all the arteries in the body, you're going to start to raise or pump up blood pressure, arterial blood pressure. Okay, so you're vasoconstricting all these arteries. Now, there's the same amount of blood in there, so the arteries are going to put pressure on the volume of blood, and that's going to raise the pressure, the blood pressure. Now, let's think about it for a second. How can you get away without memorizing all of that? Well, think about this. If you are in a situation where you are fearing for your life, let's imagine that you went on an Arctic tour and you walked away from the group and you walk around a snowbank and boom, there's a polar bear, okay? So big sympathetic response, right? Fight or flight. I want you to ask yourself, at that point in time, would you want your blood pressure to go up? Or would you want your blood pressure to go down? Okay, so if you vasodilated, your blood pressure would drop. Okay. I'll let you think about it for a second. If you were in a fight or flight situation, you want your blood pressure to go up. And the reason why is if your blood pressure goes down, you might pass out and become polar bear food. Okay. So in a fight or flight reaction, we want to be able to pressurize the brain, pressurize the muscle, and we don't want to pass out. Okay, so that's what you can remember. And it's the arteries that are going to help you do that. Okay, so that's how you remember that these arteries will vasoconstrict in a sympathetic response. Now, we also see alpha-1 adrenergic receptors on the smooth muscle in the arterioles. So here there would be alpha-1 receptors on these little smooth muscle cells. And of course, they will also stimulate vasoconstriction. But the purpose here is a little bit different, okay? Related, but slightly different. So we see vasoconstriction of arterioles in non-essential tissues. And this means, for example, the digestive system. Going out to the limbs and the skin. We get about 20% of our cardiac output going to the digestive system and about 20% to the skin. That's 40% of your blood volume. And so in a fight or flight response, when someone needs to either run and get out of there or fight the fight, okay, we don't want to have all this blood pooling in the digestive system. We want to divert that blood volume to the major arteries to keep that blood pressure up. So we see vasoconstriction which decreases blood flow to non-essential tissues. Now, these arteries under normal conditions, normal fight or flight conditions, will not vasoconstrict so much that they become hypoxic and die, okay? They may develop some ischemia, okay? So if somebody, let's imagine we have a patient and they are in a full-blown stress response because they were in a motor vehicle collision and they have broken bones everywhere, they're in severe pain. Their epi and norepinephrine levels are going to be really high and they're going to be vasoconstricting. So they usually have high blood pressure because of that. And they may start to develop some ischemia of the non-essential organs. So we have to be very careful about that. Okay, but that's more for your level 4 and level 5 clinicals. All right, so we have alpha-1 receptors found in the major arteries that help us maintain blood pressure, and then in the arterioles to non-essential tissues. We are not going to talk about beta-2 receptors. They are not found in the cardiovascular system, and to be honest, they are not very interesting. They don't do a whole lot that medications affect or pathophysiology affects. So let's move on to the beta-2 receptors. And we're going to focus here on the beta-1 receptors because they are ones that actually do help us develop or maintain blood pressure and heart function. So beta-1 receptors are found in two places in the heart. Okay, so they're always found in the heart, but two places in the heart. So the first place that they're found in the heart is in the cardiac conduction system. And everything that's highlighted in blue here is the cardiac conduction system. Do you remember? We'll actually see it. Actually, we will see it on the next slide here. Here we are. So here's the SA node, the sinoatrial node, and there are beta-1 receptors in the SA node. Recall that those SA node cells, they have this autorhythmic rate of depolarization. And if the sympathetic nervous system stimulates the SA node, heart rate is going to go up. Okay. How can you remember this? Well, if you've ever been frightened, have you heard you feel your heart rate go up, you feel palpitations? Okay. Part of that is just to increase heart function so we can help maintain blood pressure during a fight or flight response. But that's a very common response. So if a patient is very stressed, then we'll usually see an increase in their heart rate. We also see beta-1 receptors on the cardiac muscle cells in the myocardium, specifically, or more in the ventricle. But these are the contractile cells, the cells that are going to squeeze and give us a cardiac output. Okay, so when epi and norepinephrine bind to beta-1 receptors on these myocardial cells in the ventricles, it will increase contractility, and it does this by allowing more calcium to diffuse into the cytoplasm of these cells, and that will give us a greater strength of contraction. And in the end, it increases what we call cardiac output. CO is cardiac output. But you can just imagine that, if the ventricles are going to squeeze harder, they're going to pump more blood out into the aorta, or if it's the right ventricle, into the pulmonary artery. All right. That's all we're going to do is the alpha-1 and beta-1 receptors for now. The beta-2 receptors are found on the coronary arteries, and they actually have the opposite effect of the beta-1 receptors. The beta-1 receptors are very excitatory. The beta-2 receptors are inhibitory and cause vasodilation of the coronary arteries. And that should make sense. If the heart rate is up above 100 and the heart is contracting really hard during a fight or flight response, we want to make sure that the coronary arteries that bring oxygen to the heart, we want to make sure that they are fully dilated, bring as much oxygen as possible. Okay. So again, think about the logic of all of this, because you're going to need to remember this when you get into level 2 in pharmacology. All right. Then, when we think about arterial blood pressure, it's not just about the sympathetic nervous system. There are hormones that help us regulate blood volume, primarily through the kidneys. And those hormones have a pretty dramatic effect on blood pressure in a couple different ways. Okay. So we have already talked about the renin-angiotensin system just a little bit. This is a time where we're going to go over the whole thing, okay? So we've talked about aldosterone's effect. There's another hormone within the renin-angiotensin-aldosterone system called angiotensin II that's really important clinically. Angiotensin II is a potent, meaning it's a strong vasoconstrictor. And that, as it vasoconstricts, just like the sympathetic nervous system, it also increases systemic vascular resistance and therefore blood pressure. Okay. Remember that aldosterone stimulates sodium and then water reabsorption or retention in the kidneys. Blood volume goes up, and if blood volume goes up, that pumps up blood pressure. Okay. So there's two ways that the renin-angiotensin-aldosterone system work on helping to maintain or raise blood pressure. So what we're going to do is we're going to run through the whole renin-angiotensin-aldosterone system from beginning to end, and your final slide has everything on it, but I like to walk through it step by step. So the thing that activates the renin-angiotensin-aldosterone system is generally a drop in blood pressure sensed by the kidneys. The kidneys have these special cells that can sense blood pressure in the juxtaglomerular apparatus. When blood pressure drops or blood flow to the kidneys drop, we see the release of a hormone called renin. So renin is produced by the kidneys and it gets into circulation because it's a hormone. Now, renin doesn't really have any direct effects on cells, but when it encounters a plasma protein called angiotensinogen, it cleaves apart angiotensinogen and forms a new molecule called angiotensin 1. So we talk about renin being a hormone, but it actually has some enzymatic functions because it cleaves apart angiotensinogen. And angiotensinogen is just produced by the liver. So here we are, angiotensin 1 circulating through the body. Angiotensin 1 doesn't really have any direct effects. However, when angiotensin 1 gets to the lungs, it encounters a hormone called the ACE, or it's not a hormone, I'm sorry, it's an enzyme, the angiotensin converting enzyme, and it's written out in your notes. So we have this ACE, this enzyme, and what it does is it converts angiotensin 1 to angiotensin 2. And angiotensin 2 was that really important molecule that causes arterial vasoconstriction, right? So really, in the end, renin is not so important. Angiotensinogen, not so important to memorize. Angiotensin 1, not so important. But if you don't know the whole story, then you're just memorizing things, right? So here we are, angiotensin 2, and you do need to know it does cause vasoconstriction of all of the same arteries that the sympathetic nervous system affected. And that will then increase blood pressure for us. Now, whenever you're doing your flow charts like this, I want you to step back and look at the big picture. We started with low blood pressure, and the response increased blood pressure. So this is a compensatory mechanism that the body has. Blood pressure drops, and pretty quickly we'll start to see vasoconstriction, which pumps up blood pressure. Great. However, it's not over. Angiotensin 2 is the molecule that stimulates the release of aldosterone from the adrenal cortex. And aldosterone drives the reabsorption, which is equivalent to the retention of sodium in the proximal convoluted tubules in the kidney. So sodium gets filtered in the glomerulus, and immediately about 99.5% of the sodium is reabsorbed under the effects of aldosterone. Okay? Now, remember that wherever sodium goes, if water follows, and water can easily follow through water pores and channels and leak channels in the cell membranes. So we pretty much get a 1-to-1 sodium to water reabsorption under the effects of aldosterone. Okay, and that's why we saw that high aldosterone levels can lead to isotonic fluid overload. Okay? But here this is just normal physiology. We had maybe a patient who became dehydrated, or maybe they are hemorrhaging and they've lost a lot of blood. The kidneys will start retaining sodium and water. And the reason they do that is so they can increase blood volume to compensate for what was lost. And by doing so, increase blood pressure. So the end effect of both aldosterone and angiotensin 2 is to raise blood pressure in a situation where blood pressure had started to drop for some reason. So we're going to come back to this, and we will use this a lot, but in nursing, just this normal physiology is really important because patients become dehydrated all the time. They become hypovolemic. And the hypovolemia on its own isn't the big problem. It's the effect that it has on blood pressure, okay? So low volume, low pressure. And if there's a very low blood pressure, tissues are not going to be perfused, organs are not going to be perfused. And then people start to develop hypoxic injury, cell death, and then they eventually will die if we can't get blood pressure back up to normal. All right, there is one other hormone that I want to talk about. It does affect blood pressure, but we're not going to talk about it under our blood pressure diseases. Okay, we're going to talk about it in our cardiac diseases, but I cover it here because it's really tied in to this hormonal control of blood volume. So this is a hormone called B-type natriuretic peptide, or BNP. The B stands for either basically for B or brain. This molecule was first discovered in the brain, so they called it B-type, but then they also found it coming from the heart muscle. So they decided just to call it B-type instead of brain type, because that would be confusing, right? There's also an A-type natriuretic peptide that comes from the atria, but it has the same effects as the B-type. So we're just going to focus on BNP. So as your notes here say, BNP is a hormone. It gets released by the ventricles. So did you know that your heart was also an endocrine organ? Okay. So here we have a picture of that. It happens when the ventricles dilate. Okay, so if the ventricles were to dilate or stretch, that would start the release of BNP into the bloodstream. And so here's our BNP in the bloodstream. Okay, so we might ask ourselves, well, what would cause the ventricles to stretch? Well, any increase in blood return to the ventricles would cause dilation. Could be increased blood volume. It could be that the blood's whipping around the system. We're seeing an increase in venous return back to the heart. That dilates it. And there's a number of things that we're going to talk about in our cardiac section that will increase BNP levels. Okay. So then normally BNP circulates and it tries to counteract the problem or fix the problem. And what it does is it stimulates the kidneys to get rid of sodium and get rid of water. Okay, so it has the opposite effects of aldosterone. And in the end, it tries to reduce that dilation by reducing blood volume. Okay. So a lot of people will see that in different situations, there may be aldosterone and BNP being released, and people ask, well, which one do they cancel each other out? Well, in the end, BNP is not present in very high quantities, and aldosterone can be present in very potent quantities. And so in the end, usually aldosterone wins, and we'll see that as we get into some of these diseases. Okay, so then just to wrap up a little bit of this chapter on blood pressure, just a little bit of the terminology, and those of you in level 1 have probably already covered this. So when the heart contracts and relaxes, it generates a pressure in the arteries as it pumps the blood forward. And we're going to be talking mainly about the systemic arteries and therefore the left ventricle. So when the ventricles contract, that part of the cardiac cycle is called systole. And therefore the pressure in the arteries when the heart is in systole is called the systolic blood pressure. When the heart relaxes during diastole, the second phase of the cardiac cycle, then the blood pressure in the arteries is going to drop. It won't go down to 0, but it will relax. It will drop. That lower pressure is called the diastolic blood pressure. So it's the pressure of the blood in the arteries during diastole, when the ventricles are relaxing. So your blood pressure is not the same all the time. It's always going up and down between systole and diastole, systole and diastole. When we take a blood pressure using a manual cuff, so you blow up the cuff and listen with the stethoscope, you can actually listen for the high pressure and the low pressure. And you'll learn how to do that in the nursing program for those pre-nursing students. But for the nursing students, you know that you're listening, you hear nothing, and then when you start to hear the beat of the heart, that's your systolic pressure. And then when it eventually disappears, that's your diastolic pressure. So systolic pressure is always a higher pressure, diastolic pressure is always a lower pressure, and we'll look at normal ranges and things when we start talking about the disease of hypertension. All right, well, to wrap up this concept overview video, I'm going to give you a couple little unofficial iClicker questions. So you can't do the iClicker because we are asynchronous here. But here are a couple questions for you to think through, and then we'll talk about them. So the first question, when the sympathetic nervous system is activated, what is the physiological effect on the alpha-1 receptors, and specifically alpha-1 adrenergic receptors? So A, is it vasodilation of the coronary arteries? B, increased heart rate? D, decreased blood pressure, or C, vasoconstriction of systemic arteries? So think about that for a minute. All right, well, if you answered D, you were correct. That is the direct effect of stimulating the alpha-1 receptors with sympathetic neurons, or epi and norepi released as a hormone. You get vasoconstriction of the systemic arteries. And actually, norepinephrine has a more dramatic effect on the alpha-1 receptors, just as an FYI. Vasodilation of the coronary arteries, that is caused by beta-1 receptors. Increased heart rate, remember that is driven by, vasodilation of the coronary arteries is beta-2 receptors. Increased heart rate is beta-1 receptor activity. And then low blood pressure would be caused by inhibition of the sympathetic nervous system, or turning on or turning up the volume on the parasympathetic nervous system. Our second and last question is about the kidneys and the renin-angiotensin-aldosterone system. So it says when the RAS or RAAS is activated, what's the physiological effect on the cardiovascular system overall? So we're thinking big picture. So A, blood volume is reduced. B, arterial vasoconstriction leads to increased blood pressure. C, heart rate is reduced. And D, the blood becomes more concentrated. So again, think about that for a second. If you answered B, you were correct, and that's primarily through the effects of angiotensin II. If it said blood volume was increased, that would be correct, because that would be aldosterone's effect, but this says blood volume is decreased. The renin-angiotensin-aldosterone system does not affect heart rate. And D is incorrect, because as aldosterone stimulates sodium and water retention, it actually dilutes the blood. All right, well, with that knowledge and understanding under your belt, you are absolutely prepared to tackle our alterations in cardiovascular function 1 chapter when we look at diseases of the cardiovascular system.